Now we'll start the next session. It's the joint session between the EHRA and the ECRA. It's my pleasure to introduce Professor Mervat Abou-Almaati in the first session. It's AFib ablation, which approach for which patient, and then we have a hint about the EHRA activity. And Professor Mervat is the current president of the EHRA.
Yes. Bismillah ar-Rahman ar-Rahim. Thank you, Haytham. This is an interesting meeting with all young and senior electrophysiologists from all over Egypt. لا ما فيش ريكوردد سيشن. أنا بتكلم دلوقتي فين المحاضرة بتاعتي؟ طيب ماشي ما قاليش حاجة. مش فاهمة أصل أنا مديهم حاجات الكورة. ماشي مش لا. مش واخدة إخوان. فين يا عم؟
Now we'll run some short video about the activities of the EHRA and how we can join and benefit from the EHRA. Actually, I was one of the EHRA fellows in 2010 in Munich, and I think you should apply to this fellowship in order to gain some experience in the European countries.
في فيديو فين الفيديو هنا؟
So we'll start with Professor Mervat about which approach for which patient, the AFib ablation, and then we have some notes about the EHRA activities.
حاضر يا جدعان. أقول على الأفرع هاتوا. Bismillah ar-Rahman ar-Rahim. I'll start my presentation about AF ablation, which approach for which patient. As you see, four of us were preparing this presentation to be concise and up to date. Why do we ablate AF ablation? Because from the multi-center studies, it showed that reduction of AF burden improves quality of life in symptomatic patients, improves left ventricular ejection fraction, and reduce mortality in heart failure patients, and prevention of progression of AF in the young when you start ablation early. Which AF patient you should not ablate? This is a mother's advice. First attack of AF, you don't go and ablate the patient. You don't know how he is, when his second attack is coming. Long-standing persistent AF, more than 1 year, you are pressing your luck for recurrence. After you did 2 sessions or 3 sessions of AF ablation, stop doing this because recurrence is coming. If we have an old age patient, you are not in the States. My aunt underwent AF ablation in America and she is 83 years old. But here, I don't do ablations for patients above 75 years of age. Very obese patients are troublesome in anesthesia and in the results, and not more than 120 kilograms. This is my maximum. AF, as end-stage heart failure, no touch. This patient is going to die on table. AF with hugely dilated right atrium or left atrium, also, this means bad results. I will show you the studies. AF with rheumatic heart disease patient, like what Dr. Mohammed from Jordan did, this is, for me, this is obsolete, even if she is a young woman. AF with restrictive cardiomyopathy, don't touch. Annoying patient, annoying family, stay away from them because they will not accept complications, they will not accept recurrence. And the second ablation you do, you will pay it out of your pocket. When to ablate? Paroxysmal, persistent. As you can see here, ablation of paroxysmal AF is associated with less recurrence rates. So if you go and ablate early, this means you will get good result and less recurrence. The East AFNet study showed that early rhythm control therapy was associated with a lower risk of adverse cardiovascular events than usual care with patients with early atrial fibrillation and cardiovascular conditions. What to ablate? What is your strategy for ablation? PVI, other lesions? Let's see. Kumel triangle, and I like these slides because this is the first time I hear about Kumel other than the Kumel pathway. That was early in the 60s. He said there are three important components which are involved in AF pathogenesis: the trigger, the substrate, and the modulating factors. So we start by PVI only, and this is the typical for any paroxysmal AFib patient, and additional lesions are not needed in this condition. However, in persistent atrial fibrillation patient, we do not stop with PVI. In Egypt, we do the patient once at a time for life, and any other recurrences is not accepted by our nation. So when you have a persistent AFib patient, do the PVI first. We do voltage map. We use multipolar catheter to make a very good activation voltage map of the left atrium. And we go and do box lesion, and we do lines in the posterior wall, of course. And if there is fractionated electrogram, we tackle it also. The additional lines which are necessary in the persistent cases, the roof line, the anterior line, the box lesion. Sometimes it was once, Rania and I, we went to the SVC because the patient was not coming back to sinus rhythm, and we did ablation in the SVC with the care of a phrenic nerve. Left atrial appendage was introduced, but with, at the risk of implanting a device, occlusion device. Ganglionic plexi ablation is also an option. The CAFE, which are the complex fractionated electrical atriogram, there is in persistent AF, the box lesion, yes, the posterior wall. Here is the effect, the comparison of the effect of catheter ablation using pulmonary vein isolation versus without persistent left atrial wall isolation, or on atrial arrhythmia recurrence in patients with persistent atrial fibrillation. This is the CAPLA randomized clinical trial. In this randomized trial, they studied 338 patients with persistent AF, and they were randomized to PVI or PVI plus posterior wall. This empirical addition of posterior wall to PVI did not improve freedom from atrial arrhythmias compared with PVI alone, and this is Rania's opinion. This is not my opinion. I am the mother, I'm the operator, and she is my assistant. In a subgroup analysis on patients with rapid posterior wall activity, addition of posterior wall improvement, posterior wall is associated with significant improvement in freedom from AF accompanied with PVI alone. And this is here how the posterior wall would look like with the rapid posterior wall activity compared with the slower posterior wall activity. And this encourages me always to ablate and make a box. When I see this fractionated electrogram, I make a blue tag so that we can go there and ablate it. Standalone pulmonary vein isolation versus pulmonary vein isolation with additional substrate modification as index ablation procedure was studied in persistent and long-standing persistent left atrial fibrillation. And this, in some studies like the Ulster Lost AF, showed no difference in outcome between PVI alone versus PVI, CAFE, and linear ablation. In the guidelines, if you find atrial flutter in association with atrial fibrillation, either documented on the ECG or during the procedure, you have to ablate it. As you can see, Yaranya for guidelines, the third one, they are saying that use of additional ablation lesions beyond PVI, low voltage, fragmented, electrogram, ectopic foci may be considered, but it is not established. This is me. Friends, but different opinion. what is your way out when you cannot ablate a patient because she has rheumatic heart, she has very fast atrial fibrillation, she is not medically controlled? Then we do AV node ablation and implant his bundle pacing, and this we did it in some patients. Those patients with rheumatic heart who are undergoing surgery for their mitral valve, they can undergo surgical ablation, and this we did at Dar Fuad Hospital with Dr. Gamal Sami, but actually the results are not satisfying to me. How to ablate? The ablation energy you listened this morning, we have radio frequency, cryoballoon, and in this comparison, in the fire and ice study, they showed that no difference in the primary endpoint with any atrial arrhythmia recurrence or between the RF and the cryo, and that was encouraging. However, persistent AF, cryo, or RF were also compared in many studies, and they showed no difference. However, in persistent AF patient, cryo balloon showed similar efficacy and overall safety as compared to RF. Cryoballoon is associated with shorter duration, but remember the phrenic nerve and the fluoroscopy time. The advanced RF technology versus the second generation cryoballoon, this is what we mentioned this morning, and it showed that patients who underwent AF ablation using the Thermocool, Smart Touch, SF radiofrequency catheter versus the Arctic front balloon had lower cost and AF-related readmission. The new technology of pulsed field ablation, which Dr. Ahmed Taher showed us, and this was compared to RF versus cryoballoon, and the pulsed field ablation after 1 year follow-up showed freedom from atrial tachyarrhythmias recurrence in 85% with the pulsed field ablation versus 66% in cryoballoon and 73% in RF ablation. Comparing pulsed field ablation to very high power, short duration PVI, there were comparable arrhythmia-free survival in both techniques. PFA, pulsed field ablation versus cryo, and they showed that AF recurrence rate after PFA seems to be comparable to cryoballoon. There are other technologies which are not applicable. Vagal AF can be ablated by anatomical ablation of ganglionic plexi in the right atrium in 70% of patients who had vagally induced AF. What to do in case of recurrence? Recurrence here, we have, if you have a recurrent case, you have to recheck the veins. Recurrence of AF after initial ablation means pulmonary vein reconnection. Depending on the study and the patient, the rate of pulmonary vein reconnection is between 61 to 81%. Second, check non-PVI triggers, and this is difficult because they might come from the posterior wall, the roof, and there are some techniques to find these triggers. Actually, I'm not a believer, sorry. Checking low voltage area, this is very practical because you can use multipolar catheters to check for areas of scars, and then you can tackle these areas and you hope that you can ablate the patient. Here we can see that the ablation strategy, there is not a definite strategy you can be used. Similar outcome for paroxysmal and persistent AF. Left atrial size is the major predictor of recurrence. The left atrial size. Individualized approach for atrial fibrillation should be tailored by history, by examination, by documentation, by measuring left atrium, by the economy of the country, by the availability of CAR2 catheters which are not available since many months, and patients are postponed. We have waiting list of hundreds of patients, and thank you very much.
Thank you, Dr. Amarvet, for this elegant presentation. I really enjoyed it, especially the initial advices, which clearly comes from long experience. However, I have reservation about one of them, if you allow me. So about the end-stage heart failure, I think we have a study which is called the Castle Heart Transplant, which looked at these type of patients, less than 100 patients. It's not a large study, and it showed that ablation in these type of patients resulted in delaying need for transplantation or mechanical support. I know it's a small study, but it's, I thought that even those with advanced heart failure would benefit from AFib ablation. Thank you.
This condition is in special centers who have ECMO, who have anesthesiologists who will not leave the patient and stay outside the room to talk on the phone. It needs special preparation. I would not take a heart failure patient and let him or her die on table. The family will kill me in front of the hospital. So here in Egypt, I am talking about our experience in this situation.
Mirvat, in case of early recurrence, do you decide to make a redo early in the blanking period ولا late?
بص انا البلانكينج بيريد بتاعتي 6 months to 1 year. It's not 2 months like them. Because I also give the patient amiodarone, big doses, to postpone the recurrence. حضرتك يا بيه حضرتك.
ده سؤالي الثاني ان انت هل قبليها
politically you have to learn from me political how to manage a patient.
لا بس لا اصل ده كلام بتاع ماما ميرفت انما في كلام ثاني.
Okay, we do not go for recurrence early. You have to wait for 2 months. But for the patient to accept coming back to the lab and احنا تاني ablation على حسابنا فاحنا
انما بتدي روتين انتي اريزمك قبل الابليشن.
Of course, patient is on anti-arrhythmic, on anticoagulant. He stops 1 dose of anticoagulation the night of the procedure or the day of the procedure اللي هو single dose. He continues on his anti-arrhythmic medication unless I am suspecting supraventricular tachycardia degenerating to AF in young age patients. I bring him on anticoagulation, but off all antiarrhythmic. If I am suspecting SVT degenerating to AF.
And you have to wait half an hour before ending the procedure.
I have to wait?
Half an hour after you finish the procedure, you have to wait for the very early recurrence.
Okay, rechecking the veins and urania. We are a big team in Egypt, women team, strong team. What we do? We start with the one-sided veins. We make the map. We ablate, and then we make the map of the right-sided veins, and then we ablate, and we go back and check the left-sided veins, and we go back and check the right-sided veins. But after using the contact force and the ablation index, our recurrence, Allahu Akbar, is 0. Which يعني كلمة حق يعني. But because of the technology, and nowadays we do not accept to ablate any patient without contact force and ablation index, because we saw it with our eyes. We are using 50 watt until we get 550 anterior wall, 450 posterior wall.
You try in disability after you finish by pacing?
Yes, yes, of course. Each vein we check for PVPs, PVP potentials, pulmonary vein potentials, and we pace inside to check for exit block. And we make sure, and Salah Ahwani is one of our assistants in this, I'm very meticulous in this because recurrence doesn't go to Rania, doesn't go to Salah, it comes to me. I am عدوة recurrence. I'm the enemy of recurrence.
Thank you, Professor Mervat. We'll go to the next session, tips to decrease the recurrence of after AFib ablation with Sotorius Nidius. He's the EHRA Young Ambassador, and the EHRA International Affairs leader. And actually, I think Dr. Sotos has one of his round in Ain Shams University, I think in the tropical medicine, as he told me in one of our mails. So it's pleasure to welcome him again in Egypt. And I think this is a recorded lecture, and then he will be with us for the question and answer, if any. So we can start.
Dear colleagues of the Egyptian Society of Cardiology and the Egyptian Cardiac Rhythm Association, it is a pleasure to join you at ECRA 2023 at the Egyptian Heart House in Cairo. My name is Soterios Nedios, an associate professor at the Heart Center of Leipzig, and I would like to talk to you about the tips to decrease the recurrence after AF ablation. AF ablation has been a success story. If we look back to the last 3 decades of atrial fibrillation ablation, from the beginning of the pulmonary vein recordings from Hasege in 1994, the development of radiofrequency catheters that have allowed us to isolate the pulmonary veins, and the later development of single-shot devices like cryoballoons, and lately of non-thermal energy forms like the electroporation, the pulse field ablation. AF ablation has been, again, time and again, a success story. With better catheters, seats, diagnostic tools, electro-anatomical maps, and energy forms that have improved our outcomes. Nevertheless, we have seen that in the recent ADVENT trial, that the success rates after 1 year remains around 70%, despite the energy form used. This has been similar for PFA, cryoballoon, or RF. That means that 1 in 3 patients is at risk of AF recurrence. And what we have learned from the people that have come back for a redo mapping procedure, whether they had atrial fibrillation or not, in many different studies and more than 600 patients, that the majority of patients with AF recurrence had at least one pulmonary vein reconnected. So the idea of decreasing AF recurrence becomes the idea of achieving durable pulmonary vein isolation. And we have seen an increase in durability of pulmonary vein isolation with the introduction of several technologies. And this is our approach at the Heart Center Leipzig. These are the 6 key factors for achieving durable PVI with radiofrequency ablation. You need a steerable sheath, a contact force catheter with a lesion index and high power short duration, and interlesion distance of less than 6 millimeters. These are insights that have been the result of several studies that the closed AF protocol from Matthias Duitzever, and has allowed us today to achieve high-rate first-pass pulmonary vein isolation with a very short procedural and RF time, and very good clinical outcomes at 12 months. I want to emphasize the importance of steerable seats. You can see here a meta-analysis of more than 10 studies in almost 1,000 patients, where a steerable seat has achieved an AF recurrence reduction of approximately 20%, and additionally a reduction in procedural time without any complications additionally. And this has been even more evidently when contact force has been applied on the catheters. You can see here the contact force with a steerable sheath being depicted here with a blue line, and the contact force with a non-steerable sheath being depicted with a red dotted line. And you can appreciate the difference. In addition, with algorithms that combine that information of stability, contact force, energy duration, and energy level, we can approximate a surrogate of the lesion creation. And then we can use these tags in order to tag stability and effectiveness of a lesion. And combined with a high power, we can reduce the time that we need to achieve the lesion, and thus the time needed to have a stable position. And this results into almost 50% less PV reconnections seen in this meta-analysis of more than 2,000 patients, and of course, a faster ablation time. Of course, if you have a thicker myocardium, you always have to remember that you still may have to use lower power and longer duration in order to reach those deeper myocardial structures, like on the anterior wall. The achievement of a durable PVI has been a success that has become even better in the recent years, not only for the radiofrequency, but also for single-shot devices like cryoballoons and FARAPULSE, achieving similar results. One thing you have to remember once you use these single-shot devices is that you have to choose wisely. And by that, I mean, you have to keep in mind that the anatomy of each patient is different, that 1 in 5 patients has a common ostium on the left side or 3 pulmonary veins on the right. And these have been associated with higher AF recurrence rates with single-shot devices, especially cryoballoon. A posterior transeptal is also a problem if you want to reach the right inferior. A larger right superior is a problem. And a narrow pulmonary vein ostium is also a problem. So you have to know how to choose your patients, and pre-procedural imaging may be very helpful in that terms. And you have to know your moves. You have to know how to confirm occlusion and use pull back, pull down, and hockey stick to improve the outcomes. The same applies for PFA. You have to choose wisely the patients that are going to be going PVI, or the patients that may have additional substrate that needs to be addressed. And we have seen that in the initial manifest PF, the real-world registry of PFA patients that has now more than thousands of patients. And we have seen that the recurrence predictors remain the usual suspects: an enlarged left atrium and reduced ejection fraction, persistent AF, and older AIDS. But altogether, durable PVI is nowadays achievable in a similar level with all different technologies, and we have seen that with the meta-analysis of more than 19 studies and more than 1,000 patients. Keep an eye on the left atrium and the P-wave duration. These are insights into the world of the left atrium and the electrophysiology. They may help you recognize patients that may have substrate beyond PVI. And it's definitely a strong predictor of AF recurrence that increases exponentially with the duration of the P wave. So it may help you identify patients at high risk or adjust follow-up on interventions. And you may have to treat them differently if they have a normal P wave, a partial, or an advanced interarterial block. Also, keep a plan in case a patient comes back and does have isolated pulmonary veins. Our approach in Heart Center Leipzig has always been the addressing low voltage areas. And this has also been studied in the ERASE AF trial and has shown a reduction of AF recurrence by addressing low voltage areas with ablation lesions. The guidelines, though, and a recent study, the Party PVI, with different approaches in patients with durable PVI, recently has shown no superiority of one over another approach, and thus the guidelines remain down to earth by putting the durable pulmonary vein isolation as a cornerstone of the ablation goal. CTI dependent should be also ablated, but lesions beyond PVI may be considered but are not well established. Last but not least, I would say, is lifestyle modifications. The patient comes with many different problems, and they have all have to be addressed. Hypertension, diabetes, obesity, smoking, alcohol, sleep apnea, hyperlipidemia, physical inactivity. And we have seen that many times that the patient comes for a procedure, the surgery is done, and you do communicate that this is not the cure. This is this is just the beginning, and you have to do more, and you have to change your life in order to have any impact to the disease. And the patient agrees, and they are motivated at the beginning, but after 2 years, 90% of the patients don't change lifestyle at all. So do use empathy to connect with the patient and influence his behavior, accept that in an unconditional and positive regard that the situation is difficult, and but do try to communicate how important lifestyle modifications are. So I would like to conclude my take-home messages. AF ablation is a success story. Although 1 in 3 patients is at risk of AF recurrence, this has mostly been the case due to reconnected pulmonary veins. Use contact force catheters, lesion index, steerable seats, and high power short duration to improve radiofrequency ablation results. And use single shot devices because they're easy and they result into durable PVIs with similar results to radiofrequency. Keep an eye on the anatomy though, and predictors of substrate beyond PVI, and have a plan for AF despite durable PVI. Use empathy to connect with the patient. And finally, visit more ECRA and EHRA sessions to keep up to date. Thank you for your attention, and I would be happy to join the discussion with a question.
Thank you very much for the valuable presentation. So I will start with a simple question regarding the economic point of view. If you have the opportunity to get only a single way or a single method for AFib ablation, what's your choice for this to decrease the recurrence? I mean.
Thank you for the question, and thank you for having me back in Egypt. Indeed, I was in Cairo for the tropical medicine back in 2004. So the question of financial of costs is very important, and currently I think most of the countries have the most cost-effective use by radiofrequency ablation. The single shot devices are very easy to use, and from a financial perspective, the cryoballoon is equivalent, even maybe a little bit better than radiofrequency in Germany. But I know that many countries do use resterilize some catheters and make the radiofrequency ablation more cost effective to use. The fact that PFA has been so successful is something that is being currently used, and they charge a little bit of prime cost for the development of the technologies, so it's still an expensive solution. So if I would use something cost effectively, I would go with RF ablation and cryoballoon ablation. But this is a changing scene. I think we're going to see a big change in the coming years.
I have a second question. How often do you use the additional lines beyond the PVI in your patients, in your experience, the clinical experience?
Thank you for the question. So we do use the low voltage as the guidance for the substrate of the patient. This is the easiest parameter that is available during the procedure, and it's very objective. It's not very subjective as the fractionated electrograms. And we have used this approach since many years now, and even in the first procedure, if there is significant low voltage areas, we will proceed with ablation lines that transcend the low voltage areas in order to avoid having atrial flutters through that area. We also try to induce the patient before we do the lines, and it's definitely the best thing to see an atrial flutter that has been induced being terminated by a line. This is very reassuring that you're doing the right thing for the patient.
Thank you. We have a question from the floor, Professor Mu'taz.
Thank you for the elegant presentation. I would like to know your opinion nowadays that the vein of Marshall ethanol ablation now is gaining a lot of momentum after the Venus study maybe 3 years ago, to the extent that Pierre Jailly now in Bordeaux and the Michel Hesseguer group are now advocating changing their stepwise approach, which has been there for the last 20 years, to the so-called Marshall first approach, in which they are now conducting a registry and a study to examine whether just starting by ethanol ablation of the vein of Marshall, followed by actually isolation, PVI isolation, and then the line, then the box isolation, and so forth, CAFE. And they're advocating beginning with the Marshall first. What do you think about this approach? Also in terms of cost effectiveness, because we're a poor country, you know.
That's a very good question and very up to date, I think. So since the work from Valderrabano and Hesseguer in this area, we have gained new insights about the electrophysiology and especially the connections that go through the muscle vein and between the CS and the left atrium. And we have seen indeed better results. And it makes sense that when you take some part of the problem outside, when you take out the posterior wall or the anterior mitral isthmus, you eliminate some part of the problem. We do not use it regularly on patients. It's a procedure that does need additional skills, and it's not reproducible in all patients in a way that the Marshall vein anatomy has significant variation in between patients. And then you also have a lot of reconnection between the veins that you may indeed end up with a great area of the left atrium being ablated. If you see some maps that have been ablated with alcohol ablation, you can see sometimes that the whole posterior wall, especially the left side, is ablated, which results, of course, in less substrate for reentries. But we don't know what are the long-term results of that. And definitely, it's something that requires longer procedures in the AP lab and also needs additional skills. You sometimes need to use double balloon techniques in order to occlude other sideway veins that where the alcohol may spill out. This has also been the case for LVOT and septal PVCs. They have used the alcohol ablation in the distal CS vessels, and sometimes the alcohol ablation may not be so regulated as you would wish for. So I would take that with a grain of caution. Definitely, and certainly I would take that into account when I plan my procedures in the lab. And there's also a learning curve that should not be forgotten. So one is best at the thing that he's doing every day. And I think if you're gonna plan to do such cases, you should plan to do a lot of them one after the other and carefully choose the patients that you're gonna use with this technique. Additionally, we must say that nowadays, with the emergence of PFA, we're going to see less and less of that because PFA has been so effective in doing transmural lesions that having the additional risk of alcohol ablation will not be necessary probably in the future. But this is still a question that remains to be seen. I'm very glad there is the work from Hasegae and Valderrabano, because this has gave us great insights into connections and electrophysiological importance of the Marshall vein. But as we have seen in the past decades, and we will continue seeing in the future, technology is going to improve and ablations are going to be easier, not more complex in the future. Thank you.
Yeah, we have
Thank you.
another question from the floor. Professor Rania.
Thank you. I'm Dr. Rania Samir from Ain Shams University. Thank you so much for your elegant talk. I want to ask you about PFA. And from your experience, we heard reports about using PFA beyond pulmonary vein isolation in posterior wall isolation and CTI ablation. What's your experience in this? And what about the outcomes and if, collateral damage, if there's any?
Excellent question. Thank you for that. As Dr. Abou-El-Mati said in her talk, the Kapla AF trial showed that the ablation of the posterior wall was not producing any better results than without posterior wall. And there was a big discussion about whether this ablation was actually durable and whether the results were not significantly different because there was reconnection. And we have seen during the initial trials with the PFA that some centers have taken out the posterior wall as well, especially in persistent AF patients. But as you can see in the Manifest PF and the Advent trials, there was if you still hit that upper level of success rates of 70%. We have not seen much better results. I think maybe there would be some space for a future Kapla PFA trial that we will see the posterior wall is indeed better ablated with PFA and results into better outcomes, but we don't know that yet. Yeah, I want to thank you very much for the invitation and the questions. It was a pleasure, and I'm happy to see the cooperation of ECRA and EHRA growing stronger. And congratulations on the new Egyptian Heart House in Cairo.
I think we're waiting for you physically the next time, hopefully in February. Thank you very much.
Thank you very much.
So now we're gonna to the next speaker, Salah Al-Ahwani. He's the EHRA Young Ambassador from Egypt, and he will talk about the complication in AFib ablation, how to avoid.
Thank you, Professor Haitham, for arranging this joint session between EHRA and ECRA. A brief introduction. Atrial fibrillation is a common problem affecting an estimated 1 to 2% of world's population across a range of age groups. It creates a large burden of healthcare and socioeconomic costs. AF ablation is an increasingly important procedure with growing demand globally. AF ablation is a relatively safe procedure with a mortality rate of less than 0.1%. Catheter ablation of atrial fibrillation is a complex interventional procedure that has changed along the time. Nowadays, many technological advances have been incorporated in clinical practice in order to improve success rate and minimize complication. Despite that, as the volume of AF ablation procedures grow, the number of complications is also expected to increase. This is a very famous algorithm in 2020 AC guidelines for diagnosis and management of atrial fibrillation. And the guidelines is a class 1 indication to perform AF catheter ablation in paroxysmal and persistent atrial fibrillation with or without major risk factor for AF recurrence. Also in paroxysmal or persistent atrial fibrillation and the heart failure with reduced ejection fraction is class 1 indication. This table is presented also in the guidelines with the procedure-related complication with a life-threatening complication of pre-procedural death esophageal fistula, pre-procedural thromboembolic event, and cardiac tamponade. Severe complication, the most common is vascular complication, but pulmonary vein stenosis and persistent phrenic nerve palsy can also occur. Another minor indication and a complication of unknown significance like asymptomatic cerebral embolism. So the guidelines showed key issues in follow-up after AF catheter ablation, in recognition and management of complication, that the clinician and the patient must be informed about the clinical signs and symptoms of rare but potentially dangerous ablation-related complication that may occur after hospital discharge, like AF fistula and pulmonary vein stenosis. Also, the OAC therapy is continued for 2 months, regardless of Schatz-Vask score, is a key issue in the follow-up of atrial fibrillation catheter ablation. So the most frequent, severe, and well-established complication I will discuss is cardiac tamponade, how to avoid cardiac tamponade, pre-procedural stroke, pulmonary vein stenosis, and phrenic nerve palsy. Also the atrial esophageal fistula. Cardiac tamponade with a general incidence of 1.2 to 1.3%. The main reasons for high incidence in AF ablation are the transeptal punctures, the intense and long catheter manipulation in the left atrium, the use of high power ablation with risk of steam pops, and the need for intense systemic anticoagulation. Cardiac tamponade have been considered the most frequent cause of peri-procedural death during AF ablation. Also, the incidence of tamponade suggested to be lower during cryoablation, especially for the recent prospective randomized controlled trial of fire and ice trial by Karl-Heinz Cook that showed a tamponade of 0.3% in the cryoballoon arm as compared to 1.3% in the RF arm. This diagram shows the transition of invasive blood pressure during the procedure in a representative case that required pericardiocentesis. As we can see the start, the blood pressure is almost 140. After transeptal, stable, safe transeptal. Pulmonary vein venogram, it's okay. And then during left pulmonary veins ablation, we can see the drop of blood pressure and the continuation of the procedure till the need of pericardiocentesis. Here is the timing of an overt cardiac tamponade, which clearly shown that most of tamponade occurred during left pulmonary vein isolation. How to avoid cardiac tamponade? Transeptal punctures performed too posteriorly may perforate the posterior right atrium and reach the pericardial space. Very high punctures may also perforate the left atrial roof. Advancing the sheath system too deep into the left atrium may reach and perforate the left atrium appendage, left pulmonary veins, or the lateral left atrial wall. The use of different fluoroscopic views as REO to have a better anterior-posterior view of the transeptal puncture and left anterior oblique to evaluate how depths in the sheath system being introduced in the left atrium may prevent transeptal accident. Also, advancing the transeptal system over the wire positioned in the left superior pulmonary vein is crucial and important as a strategy to prevent left atrial perforation. Recently, many operators like Professor Mervat prefer to use transesophageal echo while doing transeptal for a safer transeptal puncture. Direct catheter mechanical trauma, especially through the left atrial appendage and the roof of the left atrium, are an important cause of pericardial effusion. Here, a diagram showing illustrative TE view of transeptal puncture. A shows septal tending immediately after retraction of the sheath in the bicaval view, as we say the Mickey Mouse view, shows the advanced needle, showing the advanced, figure B shows the advanced needle and the tenting of the transeptal away from the aortic root, which is very crucial, as well as within acceptable distance to the posterior left atrial wall. C shows the captured the instance of septum perforation in the same patient, and D shows the advanced introducer sheaths within the left atrium. Here also a technique used in Stuttgart Smart Ablate RF generator as a core part of technology for closed protocol guided BVI, which offers opportunity to automatically stop RF energy delivery within 0.5 seconds if the catheter impedance rises above a predefined value. The value for impedance spike takeoff is 50 ohm per 0.5 seconds. How to recognize cardiac tamponade? There is a majority of episodes of cardiac tamponade are successfully treated immediately by percutaneous and pericardiocentesis. Early recognition and rapid drainage and detection of tamponade is crucial in the management. An early sign of cardiac tamponade is a reduction in the excursion of cardiac silhouette on fluoroscopy with simultaneous fall in systemic blood pressure. Very early hypotension is also an important sign to take in consideration. Availability of the portable echo machine is important in the EP lab. Also, ICE has been helpful to early detect pericardial effusion, but in our practice with Professor Mervat, we use transesophageal echo and the portable echo machine, actually a tablet with an echo probe. How to manage cardiac tamponade? Subxiphoid puncture is the best way to achieve. A drainage catheter, anticoagulation of patient with warfarin or NOAC without interruption. Fresh frozen plasma if the patient was on warfarin. Either rosizumab as a reversal for dibigatran if the patient on dibigatran, and dilexanate alpha if on rivaroxaban, apixaban, and the edoxaban. This figure shows the echocardiographic subxiphoid images before and after pericardiocentesis. Stroke, cerebral embolism is a critical complication of AF ablation and with an incidence of thromboembolism associated and reported to be 1 to 2%. Introduction of peri-procedural management for stroke is crucial. Clinical and technical aspect implicated in the risk of thromboembolic event during AF ablation, like paroxysmal atrial fibrillation, small left atrium, low Chad's VASC score. The main mechanism for development of a stroke are thrombus already formed before the puncture and dislodged during left atrial catheter, thrombus formation in transeptal sheaths, we saw that, and also at the tip of the ablation during RF delivery, maybe thrombus at the ablation area, or thrombus formation due to prothrombotic state that occurs after ablation. This is one of Professor Mervat cases. Before going to transeptal puncture, we always use T-on table, exclude left atrial and right atrial appendage thrombus. We found before transeptal function this freely mobile thrombus, and we aborted the procedure. How to prevent a stroke? Stroke events have been reduced after applying strict preventive protocol that involve pre-procedural anticoagulation for at least 3 weeks prior ablation. Also, IV heparin is essential to prevent thrombus formation during procedure. Around 10,000 international unit is generally administered after safe transeptal punctures. ACT regularly checked every 30 minutes, and additional IV heparin is infused to maintain ACT around 350 seconds. This is a diagram showing the potential mechanisms that lead to a risk of stroke, dementia, and cognitive decline related to the procedure and not related to the procedure. How to recognize a stroke? Arterial occlusion of a major important cerebral artery shows motor deficit, dysphasia, dysarthria, and disorientation. Small arteriole might lead to visual disturbs. Also, asymptomatic cerebral embolism can be seen in MRI after ablation that related to future cognitive deficits. How to manage acute stroke is managed according to stroke protocol, and aggressive early management of acute may attenuate their consequences. It's time to break some ice now with this case from Professor Mervat cases. This is a phenomena called intracardiac drifting iceberg phenomena. Following ablation of right superior pulmonary vein, a piece of frozen contrast was detached from the vein to the bloodstream and traveled from the left atrium to the left ventricle, while decreased in size. The patient persisted asymptomatic, probably due to thawing of the embolic material during intravascular movement, and the clinical consequences. Yes, this is cryoablation. I'm saying it's a frozen contrast, and the clinical consequences of ICE embolism related to cryoablation remain unknown. Pulmonary vein stenosis was the most important complication on the beginning of experience because the ablation was conventionally inside the pulmonary veins for the foci deep inside the veins, and this scenario changed after antral ablation. How to avoid is antral ablation strategy, of course. Patients undergoing multiple procedures have the high risk of pulmonary vein stenosis, as I will show. Cryoablation AF ablation strategy show low risk of pulmonary vein stenosis on the expenses of phrenic nerve palsy using a new generation big balloon as recently demonstrated by the fire and ice trial. This is a case, a redo case. We can see the left superior pulmonary vein that showed a stenosis in the redo procedure. How to recognize pulmonary vein stenosis symptoms ranges from asymptomatic to severe symptoms. Actually, if a single vein is involved, no worry, the patient might came asymptomatic as long as he didn't get into another session, and we can see a pulmonary vein stenosis during the second 3D mapping and ablation. Common symptoms are cough, chest pain, dyspnea, hemoptysis, and recurrent pulmonary infection. It's important to have in mind that severe stenosis can also remain asymptomatic, as I said, and the percentage of the severity graded according to the percentage of reduction of luminal diameter. That's why early images examination is beneficial. This is an ICE case showing the difference before and after pulmonary vein, left inferior pulmonary vein isolation with increase in the peak velocity of the left lower or left inferior pulmonary vein. How to manage pulmonary vein stenosis, asymptomatic or mild symptomatic, even with severe pulmonary, are usually managed. I need 3 minutes. Successful BV angioplasty with a BV restenosis can occur in 50% of cases. And there is no, and the most severe complication of pulmonary vein stenosis intervention are tamponade, massive bleeding, pulmonary vein rupture. This is an interesting case showing the recanalization of an occluded left inferior pulmonary vein with a CT pre and post procedure and angiography pre and post intervention. Phrenic nerve palsy, in the past, the right phrenic nerve palsy is an important complication of AF ablation, but currently after introduction of cryoablation showed in the fire and ice trial that the incidence of a persistent phrenic nerve palsy was 0.3%. Attempts to isolate the superior vena cava also carry a very high risk of right phrenic nerve palsy. This is the anatomy of the right and left phrenic nerve as it goes the right nerve around the SVC and the dissected left phrenic nerve across the lateral border of the left ventricle. This diagram shows the occurrence of phrenic nerve palsy, which is very significant in cryoballoon arm. How to avoid phrenic nerve palsy is to avoid delivery of RF in recognized sites close to the phrenic nerve. As I said, for non-BV triggers, if we go to SVC isolation, there is a 10% chance of persistent phrenic nerve palsy. This is the various maneuvers used to prevent phrenic nerve injury, ranging from avoid long-acting paralytic during ablation till the utilize of the pull-back method to assess the depth of balloon inside pulmonary veins, with pros and cons of various phrenic nerve monitoring strategies. This is schematic presentation of one technique to avoid diaphragmatic injury. This is a proximal seal technique used during cryoablation with a simultaneous 3D mapping system to identify and annotate the phrenic nerve course, and after getting inside the vein, getting a little bit out after ensure the seal of the dye inside the pulmonary vein. How to recognize absence of diaphragmatic excursion on fluoroscopy, new elevated diaphragm, as this is the position of catheter during superior vena cava placement of a decapolar catheter to ensure a phrenic curve capture during right superior pulmonary vein cryoablation. Just 30 seconds. How to manage phrenic nerve palsy? Okay, I will get into conclusion. This is also the atrioesophageal fistula with diagrams to avoid and recognize atrioesophageal fistula. And this is the flow chart. To conclude, a proactive and alert EB team is the one and only approach to avoid life-threatening complication of AF ablation. Pre-procedural monitoring of the borders, phrenic nerve injury, ACT, blood pressure, and worrisome symptoms in the follow-up for as soon as possible recognition and prompt aggressive management of complication. So don't ever fire or even freeze and forget, as your patient might face a dramatic deadly end. Thanks for your listening.
Thank you, Salam.
yeah, that's the ERA slides. I will show the ERA mission, which is improving the quality. Okay, which improving the quality of life and reducing the sudden cardiac death by limiting the impact of heart rhythm disturbances. This is the EXCO members with Professor Jose Merino, the president. The upcoming ERA meeting will be in Berlin from the 7th to 9th of April. There is a lot of upcoming webinars, educational courses, and of course the EP Europace journal. We want to apply for an ERA recognized training centers. If any center is eligible, can apply for the recognized training center like critical care unit in Cairo University. There is also ERA books and website for patients, and the key messages in the Pocket by ERA key messages application. The AEC e-learning and the cardiology education hub shows 2 tracks, device track and EP fellows track. The key reference library with 400 cutting-edge publication. So join ERA for a new single ERA Silver membership and get the benefits. Under 40 or still in training, ERA is providing a discount on the membership fee. ERA is your community for career education, science, and of course the Congress. Recognition of excellence is for a fellow of ERA like Professor Mervet is a fellow of ERA. ERA Scientific Initiative, to join the ERA Scientific Initiative research and surveys. And finally, meet the ERA news on Twitter and LinkedIn. Thank you.
Thank you, Salah. So now we are with the recorded lecture from Professor Jose Luis Merino, the current president of the ERA, and the topic about new technologies in AFib ablation, how it impact the outcomes.
Hello, my name is Dr. Jose Luis Merino from La Paz University Hospital. It's a real honor and pleasure to represent ERA in this joint session with the European Heart Rhythm Association. And my task for today is to discuss with you new technologies in AFib ablation, how it impacts the outcome. These are my conflicts of interest. So when talking about new technologies, the first thing is to discuss whether there is something new about RF. And there is something new, relatively new, that is high power short duration. We know that conventional RF application results in 2 different ways of heating, resistive and conductive heating. So if we increase the power and decrease duration, we mostly favor resistive heating. And this may have some advantages. One is obvious, that is reducing the procedural time. And secondly is a potential decrease of the risk of damaging collateral organs. Initial results were promising, suggesting a higher efficacy and even a safer procedure. However, we decided to test this way of ablating in a randomized multicenter trial that was presented last year or this year in the ERA Congress. And basically, we randomized patients to conventional RF application with guided by ablation indices versus high power short duration using 70 watts for 9 seconds. Patients were followed with daily ECG transmissions, telephonic, for 1 year, and all of them had an esophageal endoscopic taken the following day. Here you see results at long-term or at follow-up, so no differences, even a trend towards lower efficacy in the high power short duration arm. In terms of complication, again, no differences. However, if we go into detail, there were significantly more stroke and systemic embolism in the high power short duration arm. How this was, what was the cause of this? there are several potential causes. One of them could be the catheter use, and this is why there are new catheters in the market. One is the Diamond 10 that provides the possibility to monitor temperature during RF application, and also to somewhat extract some heat from the tissue. And this is due to the characteristic of the tip that is mostly done with diamond. So it's mostly made with diamond that has a more powerful diffusivity effect than platinum, that is our standard material in conventional RF catheters. There are other potential future approaches using RF, that is RF balloons. However, at this stage, it's unclear whether they will survive in the era of PFA. What about cryo? There is something new about cryo. Yes, something new is ultra low temperature. There are at least 2 different companies working on this. You see one of them, one of these catheters that may adopt different shapes, and in general, for PVI ablation, the shape is circular. You place this circle on the PV ostium and freeze. It's a powerful tool. You see here in our lab one of these catheters, and how the tip is frozen, and you need to be careful because it's so powerful that if you don't pay attention while doing this experiment, your fingers may end attached to the catheter, like was the case for my fingers. Okay, there are some preliminary results in a non-controlled study. You see that they were promising both for the entire group of paroxysmal persistent, but also for persistent alone, over 80% freedom of atrial fibrillation at 1 year follow-up. Still, we need to wait for control or ideally randomized trials. But probably what is more interesting is what is new is PFA. There is a new energy that is based on ultra-rapid electrical fields that eventually lead to nanoscopic pores in the cellular membrane that results in cellular death. The interesting, one of the advantages of this energy is that there are different tissue sensitivities. So the sensitivity is low for blood vessels and nerve fibers, which are very resistant to PFA, but is high for cardiomyocytes. And in fact, this is what we are looking for, because in order to avoid damage to the phrenic nerve of the esophagus, this appears to be an ideal energy different to RF or cryo. This was, or this is, the first catheter placed in the market, the Farapulse from Boston. There are others recently released, like the Fera one from Medtronic, and there are other ones coming. Initial results were presented by Viver Reddick, and interestingly, they were able to isolate all veins in the first 100 patients with a short procedural time. Reddick presented also the event trial during the ACC Congress, eventually published in the New England Journal of Medicine. You see that in terms of procedural time, the procedure was shorter compared to cryo and RF, and in terms of fluoroscopy, a little bit more fluoroscopic time. What about 1 year results? Here you see that there were no differences between the 2 types of ablation, so it appears that it's faster, but maybe it's similar in terms of efficacy. What is next? Maybe next, cryo-PFA. This is something that may have potential advantages, combining cryo and PFA, and this is currently tested in the parallel trial. Finally, some few words about artificial intelligence guided ablation. And there are some initial experiences published 1 year ago. So with these techniques, they were able to localize some sites of interest that were eventually ablated, leading to sinus rhythm conversion in most patients. Results of follow-up were promising, so freedom from atrial fibrillation recurrences, over 80%. It's still promising, but very premature. We will need to have control data to see if this is the way to go. So to finalize my talk, some take-home messages. Number one, high pulse duration RF application appears to be similar in efficacy and safety to conventional PVI ablation. However, it appears to have higher embolic risk. Cryo ultra low temperature shows promising results, but they need to be validated in randomized clinical trials. What about combining it with PFA? Future will tell. And number three, PFA, which appears or which has shown promising initial control results, but still there are some open questions, like is faster, is clear, but is it more efficacious? This is unclear. What about transmodality of lesions? What about contact dependence? So thank you for attention, and please remember, tag your calendars, that next year we'll be celebrating our EHRA Congress in Berlin. So I hope to see you all there. Thank you.
Thank you. Thank you very much. Hi, Professor Marino. It's our pleasure. Can you
Hello.
hear us?
Good afternoon.
So the floor is open for questions. Professor Marino?
You mentioned the ultra cold cryo, the new energy. Do you think it will be more beneficial than the current freezing energy cryo balloon, the new generation of cryo balloon?
Difficult to tell. I think that we only have one trial that was not controlled and, of course, not randomized, showing very good results, because even in persistent FE cases, they had over 80% freedom of atrial fibrillation recurrences at 1 year. But we have witnessed in the past many promising technologies that eventually fail, so we need to validate these results in a randomized clinical trial. Probably what it will be more interested that for a FIP, I think it could be for DT, because with this ultra-low temperature cryo, you can get very deep lesions, down to or up to 30 millimeters depth. So future will tell. Now we are in an era of technology explosion. There are many new things appearing. And always, I think that they need to be validated in terms of efficacy and safety with control trials.
I have a question about the laser and the ultrasound energy. They are vanished from existing. Why?
Yeah, exactly what I was saying, Professor Merbat. Initially, you get very fancy technologies that with very promising initial results. But then when they are tested in a long run, either because you get, let's say, large registry data or you have control data, then they show that they are not so promising. So with the ultrasound, there was some problems regarding atrioesophageal fistula, and this was mostly the reason why this technology was stopped at that time for PVI. For laser, I think it still is a good technology. We had experience with that, and it was quite nice, especially with the new balloons that are more compliant and you can also automatize the way the laser balloon beam is managed. But I think that they have decided not to keep marketing this technology in Europe, just in US. And probably the reason is because PFA will be a very strong competitor.
I have a question about your opinion about the ethanol ablation of vein of Marshall. Do you count it one of the coming technologies or something like this?
Yes, it's a good point. It's not that technology is a way to go, in fact, but yes, it's a good point. To date, it's one of the few approaches that have been associated in a randomized clinical trial with increasing success. So now this is becoming very popular in certain countries. For example, in Spain, there are many people using this approach in order to get this extra benefit. However, I don't know if this is the way to go, because it implies some expertise in something that we are not very familiar with. That is manipulating wires and catheters that are more in the field of interventional cardiology. So I am a little bit curious about that. What I see ethanol infusion, at least at the short and medium term, more interesting is for VT ablation. We had a live course or live symposium last week in Spain, and Miguel Valterrábano, you know that he was one of the first using this technique, treated some patients live, and it was quite impressive because with PVCs that were not ablated after several procedures with the standard RF approaches, he was able to get rid of these cases. And also, importantly, he has already checked what is the size of the lesion, the volume of the lesion created, and apparently is not resulting in a very large, let's say, unacceptable volume of lesion. So maybe for that specific indication, probably could be promising.
Perfect. Any question from the floor? Thank you, Professor Marino, for your presence. So we have a little presentation about the EHRA activities. Professor Mervat is the president of the EHRA, and we have a little presentation. We would like to share it with you.
Yeah.
Thank you. Thank you very much.
It's my
Honor
pleasure to become
the here.
Thank you very much, Dr. Jose Moreno. It's my pleasure to become the president of EHRA. African Heart Rhythm Association has many activities. Okay. Okay. The constitution is formed of the EXCO committee, and these are responsible for the missions and the vision of this association. We have the working groups. We have 15 working groups responsible for the scientific activities and the annual plans for progression of education. We have the EHRA regional representative, North, East, West, and South Africa, so that all regions will be represented. But we made an example of EHRA, and we had the EHRA country ambassadors from 54 African countries. We are inviting them to join us in order to be active part of EHRA. These are the 15 working groups of EHRA. We have special groups for rheumatic heart disease, for sudden cardiac death in Africa, heart failure, pediatric, sports, AF, pacing, electrophysiology, EHRA education and certification, Congress, allied professional we are taking care of them, digital platform and digital health. The EHRA certification we are imitating the EHRA certification, one for pacing and one for devices and one for allied professional. For the pacing, we have courses. The candidate should apply for the certificate and should attend these 12 courses either over 1 year or 2 years, and he has to pass a test after each course. We have done this is the EHRA certification for cardiac electrophysiology. Any cardiologist can join. We have also 12 courses over 1 year. If you are active, you can finish them. You can study with us on the platform of Zoom in order to, at the end, to take our EHRA EP exam. Our EP certification is not including 3D because we know the limitations in Africa, and we are concentrating in this certification on basic and advanced electrophysiology using conventional ablation. The 3D will be another certificate to be given to them. Our allied professionals who are engineers, nurses, and technicians, also they will have their own certification after 1 year of education of 12 courses. I hope that everyone can join us in the EHRA, either in the working group, as a member, as a country ambassador, or as an active EP fellow anywhere. Thank you very much.
Thank you, Professor Mervet. We are looking for a cooperation with between the ECRA and the EHRA very soon. Thank you, Professor Merino, for being with us, and we're looking forward more cooperation with the EHRA very soon. Thank you. So we'll conclude. Thank you very much. We'll conclude the session.